So we're going to talk about chest pain risk stratification, something that I'm sure all of us in acute care medicine are always dealing with, always trying to figure out what's the optimal way of risk stratifying patients with low-risk chest pain. The term low-risk chest pain is kind of a misnomer because that's what we worry the most about, these so-called low-risk chest pain patients. And specifically, we're going to be talking about low risk for ACS. So we're not talking about low risk for PE, we're talking about ACS here. Let's jump right into a case. And we're going to go back a few years to 2012. This is a real case, which I know of from 2012. I'll talk about how I came to know about this patient. This is a 36-year-old woman who presented to the emergency department with sharp chest pain this morning while she's at work. She's actually sitting at her desk when she kind of looked bad, and her coworkers made her come into the emergency department. She herself, I don't think she would have come in had it not been for her coworkers. And here's a bit more information. She had some nausea. She actually vomited once. She said she got dizzy, one of my favorite words. And when she said dizzy, she meant lightheaded, so we're not heading down a vertigo pathway, all right? She got a little lightheaded. She broke out in a bit of a sweat. There's no radiation, no shortness of breath. She actually says that she's had a few episodes over the past few days, although now she's sitting in front of you, totally asymptomatic, feels fine. She smokes a half-pack per day of cigarettes, really doesn't have any other known cardiac risk factors. Her blood pressure is a little bit elevated, 150/90, which is like many patients in the ED. On a normal day, that's relative hypotension. We'd be starting her on some epi. Her exam's pretty much normal. EKG just shows NSJ, non-specific junk. So you can't ship her up to the cath lab. She doesn't have a STEMI. She's not going straight to the CCU. This is a pretty common patient. How many of you have seen this patient during your last shift? Right, everybody, multiple times. And my question then for you is, what do you do, at least to think about, you don't have to raise your hand, but what do you do when you see this all too common patient? We'll make this multiple choice. I'm going to give you some choices here, all right? What's your plan? Number one, admit or obst the patient and pretend you're not sitting in a lecture on risk stratification and you didn't just have a med-mal type of lecture a little while ago. But with that patient, you usually admit them and then get the stress test or coronary CTA. Choice number two, get some serial troponins and then send her for outpatient stress test in the next 72 hours. Or how about just serial troponins and then just have her follow up in the next week or so with the primary care doc. Serial troponins, then you're done. You just discharge her without any further recommendations for a workup. Or maybe just one troponin, or EKG is non-specific, atypical symptoms, just get one troponin and then be done with it. Or maybe just discharge now. I'm so not worried about ACS, I'm not even going to do anything more than the EKG. No troponins, no labs or anything like that. Maybe a chest x-ray is okay. Or maybe, how about choice number 7, pretend you never saw her, right? Stick that chart at the bottom, go see the ankle pain and hope that your partner picks up that patient, right? Well, I work in a inner city system with probably about 70 docs staffing a number of different hospitals. And honestly, I would say that amongst my colleagues, they would choose every one of these, maybe including 7, all right? So this is really common. And when I pose this question outside of lectures, there's really a lot of disparity amongst what people normally do with this. Now, I'll tell you why there's some disparity. I've highlighted some of the things that which to me sound a bit reassuring on this case. So first of all, it's a 36-year-old woman, relatively low risk. We talked about issues with atypical presentations before, but still 36-year-old women are at lower risk than if it were, say, a 65-year-old man. It was sharp. I've learned that the word sharp is lower risk than if she said pressure. It occurred at rest. I'd be a lot more worried if she said she was walking up the stairs when she got pain. No radiation, no shortness of breath. I'm happy about that. She's had a few episodes over the past couple of days, and yet she's still alive. That's got to be good, right? And now she's asymptomatic. I'm glad to hear that. There's not much in terms of cardiac risk, and the EKG doesn't show obvious abnormality. So all of these things I'm pretty happy about. But then spinning this around, there's also a few things up here that I'm kind of worried about, all right? I'm going to highlight rest again. So the reason I'm highlighting rest now as being concerning is because what's rest pain called? That's unstable angina, right? Isn't that what we learned? That's one of the definitions for unstable angina. So maybe that's not good, She didn't have radiation or shortness of breath, but she did get nauseous and she vomited once. Vomiting's not good. And she broke out in a sweat. I hate when patients break out in sweats. Sweats is really, really bad. She got some lightheadedness. What else? She's had a few episodes. I'm going to highlight that as being concerning now because that could also be unstable angina, right? Unstable angina comes and goes, so maybe that's unstable angina. She doesn't have much in terms of cardiac risk, but she does smoke a half-pack brand of cigarettes, and she's a bit hypertensive, so maybe she's got previously undiagnosed hypertension, so maybe she's got 2 cardiac risk factors there. And I'm going to highlight the EKG again. It's not diagnostic, but on the other hand, it's also not normal, all right? I'd feel a little bit better if it were truly normal, but there's some non-specific stuff up there. So there's some things that have us a bit concerned, some things that are making us feel a little bit better. And the result of all this is that when you look at what people do with these patients, their workups are all over the map, right? Some will do choice number 1 and clearly admit to the ICU and push for stress testing and everything. Some people won't do much of anything. And I don't know if there's any nurses here, but our nurses get particularly frustrated with the workup. They try to start the workup at triage, and the workup that they initiate will depend on who the attending is. The residents do the same thing. They know that if you're working with this attending, he hates troponins. If you're working with this attending, person's got a paronychia, send troponins on him, right? It's all over the map. And so the residents will order things based on, and when you guys were in training, you probably did the same thing, depending on who's working. All right, so there's a lot of confusion. Let's go back to the case. I mentioned this is a real case. What actually happened here? Well, the EKG was okay. So what did the doc do here? The physician said, you know what, I'm going to get a chest x-ray. That sounds reasonable. Labs, he also got a D-dimer. All right, that's reasonable. Everything turned out normal. The CBC, the Chem 50, the D-dimer. He even got a troponin. The troponin was negative. And so the patient's told, follow up with your doctor. No specific recommendations, no mandatory stress tests, but pretty decent workup, all right, including a troponin. Figure if she's had on and off chest pain for 2 days, we're going to see a bump in troponin. Well, what ends up happening is the next day she had a cardiac arrest, and she died, 36-year-old woman. And that's how I came to know her. This ended up in litigation, and I was trying to help with defense of this case. Autopsy showed a massive MI with an occluded LAD, 36 years old, without much in terms of cardiac risk factors. All right? So there's Johnny. Lawsuit gets filed. All right? And what exactly is the plaintiff side going to contend? And what I would say is that probably until 2016, this is how every one of these cases would go. So their contention is the following, or actually our defense was the following. She had an atypical history. That puts her at lower risk. It's relatively low cardiac risk. The EKG was not diagnostic. This is what we're trying to argue. She even got a troponin, and it was negative. So this is our defense about how we're trying to say, you know, it's reasonable for the physician to have not thought about cardiac disease here. All right? What does the plaintiff side say? Plaintiff says, well, wait a second. You started, this goes back to your question, you started the workup by sending a troponin, and yet you didn't follow the guidelines. All right? You obviously were concerned enough to start a workup, and then you didn't go all the way. The guidelines were not followed. These are national guidelines that are written by world-renowned physicians all over the world, especially in the U.S., since we're talking about the U.S. guidelines, that say if you're going to start the workup, if you're worried about one of these so-called low-risk patients, you need to follow the guidelines. What makes you think that you're smarter than all these nationally published people who have written these guidelines? By the way, the guidelines are also endorsed by every major society, and there's even emergency physicians that are authors of these guidelines. What makes you think that you're smarter? All right? And this resulted in an upper six-figure settlement. And when I got brought into the case to help defend it, I was a bit despondent to find out that the defense attorney pretty much already told me, you know what, we're going to lose this case. Your job is to help with damage control. Your job is to minimize the settlement, all right? So it's kind of disappointing to find out that he already knows that we're going to lose this case. And my job is just to see how low we can get the settlement, all right? Again, every case ended up going that way. All right? So again, Your Honor, before we settle on judgment amount, we like to know how much money there is in the universe. It's certainly not a court that you want to be in, all right? Well, what's the deal with the guidelines, all right? We'll talk a little bit about what the guidelines say in just a moment. But up until around 2015, 2016, what I would see in all of these cases, and I've probably been involved in maybe about 60 ACS-related cases, chest pain and ACS cases over the past 12 years or so. right? And the consistent thing that gets brought up in litigation over and over, and also in the med mal literature, is number one, ACS is not just MI, right? We could rule out MI like that. Just send troponins on everybody. You'll always rule out MI. ACS is MI, but it's also ischemia. Troponins only rule out MI. To rule out ischemia, you need to do a provocative test, like a stress test. Or the guidelines allow you to substitute a coronary CTA if you can't get a stress test, all right? Now again, this is all pre-2015, 2016. So if you're starting to get it a bit despondent, hang in there. Or there's some brownies in the back to hold you over till we get to the good news, all right? Most litigation doesn't occur for missed MI. We don't get sued because we're missing MIs. We get sued because we're missing unstable angina. We're missing ischemia, which then a day or two later then goes on to develop or hours later then goes on to develop the infarct. That's why I said earlier, about half the cases I've been involved in were patients that had negative troponins on the chart. They weren't infarcting at the time the physician was taking care of them. They infarcted a little while later. But our job is not to just rule out the infarct right now, but also to rule out what might be infarcting a little while later. Secondly, traditionally, national guidelines call for troponins for ruling out MI, but the provocative test or the coronary CTA, all right? And the guidelines generally are used as a surrogate for standard of care. Now, guidelines were never intended to be used as standard of care. Guidelines are just guidelines. They're things to think about. But that's not how juries see it, all right? And a half-decent plaintiff attorney can very easily pull out the guidelines and say, this is the standard of care. It's not that difficult to convince a lay jury that this document, which is endorsed by all of these national societies and has 150 references and world-renowned authors, that represents standard of care. And this physician thought he was smarter than all of these other physicians. He went rogue, and that's why Mrs. Jones is dead, and these 3 kids have no mother anymore. So here's the guidelines. I'm going to blow parts of this up for you in just a second. This is an algorithm which essentially represents what the guidelines have traditionally been. Again, maybe up until just a couple years ago. All right? So what these guidelines say at the very top, if you have symptoms suggestive of ACS, you're supposed to put people in one of 3 different groups. Now, I've crossed out chronic stable angina. That's a little bit more relevant to outpatient medicine. But the 3 other boxes, we're supposed to take patients and put them into one of 3 boxes. On the far left is non-cardiac diagnosis. This patient's history and physical is so clearly not cardiac, I'm not even going to start a workup. It's completely reproduced chest pain. They just got punched in the chest. I don't know. Something clearly non-cardiac. Anybody who'd reasonably look at the chart would say, yeah, I'm not going to work them up either. Those are pretty easy cases, right? On the far right is definite ACS. Patient's got chest pressure, diaphoresis, radiating down the arm. That patient's clearly coming into the hospital. Nobody is going to cause any argument about that. Those are pretty easy cases also. The tough cases are box number 2 right down the middle, where it says possible ACS, like the case we started with. There's a few things that make you worried and a few things that are not so worrisome. And what do you do with those patients? You know, you try to admit them, maybe you're even going to get some argument there. We've all been in that boat, all right? So box 2 is where all the problems come in. So what do the guidelines say you're supposed to do if they fall into that middle zone? Well, what the guidelines say you're supposed to do is you get the EKG, and if it's diagnostic, well, then they go over to box 3, definite ACS, piece of cake. But typically they're in box 2 because their initial EKG and their initial troponins are unremarkable. And if the initial troponin is unremarkable, what are you supposed to do next? Well, you can come down here where it says consider myocardial perfusion imaging, all right, which is a fantastic idea. How many people here can get a sestamib during your shift? All right? So 1 person. Okay? Probably about 10 years ago, it was all the rage in the literature. And there were more hospitals doing sestamibs. It's actually quite a good test. If somebody's actively having pain, you inject the tracer, send them over to radiology, they get the sestamib test, and you can rule them out pretty quickly. The problem is we don't have that available too much any longer. Some people never had it. Even at my big tertiary care medical center, you know, I probably get 1 sestamib per year. And it has to be perfectly timed. It has to be like a Monday or Tuesday morning that they come in, and the lab has to be not busy because they turn that troponin around real quickly. EKG is not diagnostic. And then I get them over to radiology to inject the tracer before their 10:30 lunch begins, all right? And then they have to get the final read done before 3:30 because that's when the radiologists are heading home, all right? So that happens about once a year for me. And when it happens, it's great, all right? It used to be more common about 10 years ago when the literature was pushing it, but it's not very common. So that box MPI, if you can get it, it's fantastic, but most of the time we can't get it. So what do you do instead? Well, you get serial EKGs and serial markers. That's what the guidelines say you're supposed to do. If those are positive, piece of cake. They go to box 3, they get definitely admitted. All right? That's easy. Well, what happens if your serial markers and serial EKGs are still not diagnostic? Well, the next step is not to go home. It doesn't say you get to go home. The next step is not go home. The next step is you need to do the provocative test or the MPI. All right? So patient comes in non-diagnostic, you get one EKG, one troponin, it's all negative or non-diagnostic. Next step, get more EKGs and another set of markers. If those are still negative, they don't go home. The next step is to get a provocative test or coronary CTA. Now, the caveat here is that the guidelines do specifically say that if somebody is low risk, you can get the stress test within 72 hours. So they do allow you to discharge low-risk patients home as long as you're scheduling that stress test within 72 hours. But they don't exactly say, they don't clearly say what low risk is. They just say if they're low risk. But what happens is if you send them home and they die in 48 hours, everyone's going to argue, well, clearly they didn't meet low risk criteria. They should never have been sent home. The guidelines say low risk only goes home and then gets a stress test within 72 hours. And they don't define what low risk is. So that's where all the argument is. So the bottom line is, if you're going to start the workup, you need to go all the way. You don't do it kind of half-heartedly. All right? So can we discharge patients without provocative testing? Is it defensible to not follow the guidelines, and are the guidelines standard of care? Well, again, who decides malpractice in a medical malpractice case? Who decides standard of care? It's not the judge. It's not the experts. It's not the attorneys. It's the jury, consisting of not your peers. These are people whose medical expertise is based on watching Chicago Hope and Rescue 911, and if they're a little older, maybe ER, most of the time focusing on George Clooney, perhaps, all right? Not really the medicine. So it's people who don't really understand. And I'll tell you, it's a piece of cake to convince a jury that that document, as I've said, which has world-renowned authors and 160 references, and is endorsed by all these major societies, and at least one of the authors is an emergency physician. It's very easy to say, this is how you're supposed to manage low-risk chest pain. All right? Is it possible to not follow the standard of care? Absolutely. It absolutely is. But if you're not going to follow the guidelines, you need to have validated literature to back you up. So, for example, I don't follow ACLS. All right? If somebody's got VTAC or VFib or whatever, I don't follow ACLS to a T. There's a few things that I'll do in ACLS, but a lot of ACLS has been shown to be wrong. So if somebody said, well, Dr. Mattu, how come you're not following ACLS? I'd have a stack of literature this big saying, these are the articles which tell me why ACLS is not standard of care, and these are the articles which say why I'm not going to follow ACLS all the way to the end. All right? There's good validated literature to say why you don't have to do certain things. But what about with low-risk chest pain, pre-2016? If you don't follow the guidelines and somebody says, what allowed you to not follow the guidelines? Show me the validated literature that said you could deter from the guidelines. You'd pretty much have an empty hand. All right? So in other words, this is oftentimes what I refer to as my Mr. Miyagi rule. All right? Everybody remembers the Karate Kid from the 1980s. Not the more recent Kung Fu Kid with Will Smith's son. Good movie, but it's not the Karate Kid, all right? The original Karate Kid, 1980, you remember when Mr. Miyagi's sitting down with Daniel-san before Daniel-san's beginning his training. He sits down with Daniel-san and says, Daniel-san, man walk left side of road, okay. Man walk right side of road, okay. Man walk down middle of road, squish like grape, right? And then he said, karate, same way. My accent's not too good, but karate, same way, right? Either karate do or karate do not. Karate, squished like grape. And then he said, ACEP evaluation, same way. You know, he did. It was on the director's cut. Check it out, all right? So, same thing. If you're going to start the workup, you go all the way. Otherwise, don't start. And honestly, pre-2016 again, it's a lot easier to defend cases where patients come in with atypical symptoms, they get an EKG. Nobody argues about the EKG. It's part of so many workups, right? I've never heard an argument about getting an EKG. But you do history, physical, EKG, and document why you're not worried about it and send that person home, compared to the same exact scenario, history, physical, unremarkable EKG. Let's get one troponin is negative and then send the patient home. It's easier to defend the case where there was no troponin sent than the case where there was one or two troponins that were negative and then sent home. Because invariably, they go right to that algorithm and say, doctor, you started the pathway, you opened the door to the workup, and you didn't close the door at the very end. You just did your workup, and the lawyers come and squish you like a grape. All right? Case after case after case after case. All right? It's easier to defend not even starting the workup. Right? You might still get sued, but it's easier to defend that case. All right? Well, I keep saying 2016, and why is that? Do we now finally have validated literature to say, you know what? We probably don't need to exactly follow the guidelines with a provocative test or coronary CTA in every single case. All right? In fact, we've now got literature suggesting that maybe those guidelines are actually harmful, believe it or not. All right? So how can it be that a stress test is harmful or coronary CTA is harmful? Well, let me pose this question to you, all right? What's the purpose of doing a provocative test or coronary CTA in the first place? Like, where did this idea come from? What good is a provocative test? What's the purpose of doing the stress test? Well, right, you want to see if you can reproduce symptoms, right? Well, again, maybe it's fun to reproduce pain in someone. I don't know. But what exactly are we proving? Why are we trying to do that? Essentially what we're doing is we're trying to see if we can reproduce ischemia, because the presumption is that if somebody has recurrent ischemia, in other words, if we plop them on a treadmill and increase their myocardial oxygen demand, and you want to see if the supply meets the demand. If the supply doesn't meet the demand because they've got a big lesion, they develop chest pain, ischemia on EKG. And so the purpose of the stress test is it's an indirect way of finding out whether somebody has big coronary lesions. Well, again, who cares if somebody's got big lesions? What difference does it make? Why do we even care if somebody has lesions? So what if you've got lesions? Well, the reason we care about it is because we can do something about it, right? If somebody's got lesions, we can send them for PCI and put a stent in them. Not we, but the cardiologist. Or maybe they get a bypass, and the presumption is if you put a stent and open up the lesion, or do a bypass, give them new vessels, they're going to have a better outcome. That's the whole purpose of doing the stress test, because you want to find out whether in the end they're going to end up needing a PCI or CABG, and the reason that they need a PCI or CABG is because they're going to do better with PCI or CABG. All right? What if, for example, what if I told you that if they have a positive stress test, they're going to get a PCI or CABG, but hey, by the way, PCI and CABG turn out to be totally unnecessary procedures and don't improve outcomes. Would you still want them to do that? Of course not. All right? So hold that thought for just a second. All right? Is there enough evidence now to stray from the guidelines? Well, here's a couple of articles that I'm just going to summarize. And these two articles were published in 2017, but there's probably been at least a half dozen more articles showing exactly the same data. over the past several years, actually going back about 10 years, all right? And let's look at the data. So this first article, they looked at 1,000 patients presenting to the ED with chest pain that was not obviously ischemic. So it wasn't a slam dunk ischemic patient. And they compared clinical evaluation. In other words, they compared history, physical, EKG, all unremarkable. So I'm done. Go home, we're done. Versus history, physical, EKG, they're all non-diagnostic. And therefore, I'm sending you for a stress test or coronary CTA. That's the traditional workup, right? So they compared people that didn't get coronary CTA or stress versus people that did get coronary CTA or stress test. And what did they find? Was there any difference? Well, first of all, the people that got the stress test or coronary CTA had a higher length of stay, LOS is length of stay, higher cost, and increased rates of further testing. And they also looked at 28-day major adverse cardiac event. What did they find? Well, length of stay was higher when they got mandatory testing, no surprise. Cost is higher, no surprise. More people ended up getting PCIs, more people got CABG, NS is non-significant, so it wasn't a big significant difference. So the bottom line is the people that had unremarkable history, physical, EKG, who had no testing, versus people that had unremarkable history, physical, EKG, and mandatory testing, there's no difference in any of these parameters. But what about major adverse cardiac event? Surely the people that got the stress testing had better rates of major adverse cardiac events at 28 days. Not so. No difference in rates of adverse events after a month. All right? Well, here's a study where they said, you know what, let's not just look at 1 month outcome, let's look at 1 year outcome. 900,000 patients. History, physical, EKG, unremarkable, and that's all you're going to get. Versus history, physical, EKG, non-diagnostic, and you have to get a stress test. All right? And let's compare how they do in 1 month, and also let's see how they do at a year. Clearly, the people that have the mandatory stress test are going to have better outcomes because they're going to end up going for PCI and CABG, and that's going to be associated with better outcomes. Well, what they found is that at a year, the people that had the mandatory stress test had more angiograms, no surprise, more additional revascularizations, no surprise, more acute MI admissions. They had more admissions for MI after getting the stress test and interventions. Slightly more, there's no significant difference. At 30 days, same thing. All right? So the bottom line here is that when you take patients that have fairly unremarkable history, physical, EKG workups, and you force them to go through the national guidelines with the mandatory stress test, it increases their length of stay, it increased the costs, it increased the number of invasive procedures that they end up getting, but their outcome at 1 year is no different. So why are we doing these tests in people that are low risk, right? And again, there's at least a half dozen other articles just in the past few years that have found the same results as these two articles. I'm not going to go through all 6 of them. I'll just show you these 2 as a representative. In fact, here's some of the articles, article after article after article, showing stress tests do not predict the need for invasive therapy, and even invasive therapy in low-risk patients doesn't improve their outcome. All right? Now, if somebody's high risk, then we're not questioning that. If somebody's high risk, then they need a PCI or a stent. But if somebody's low risk, meaning history, physical, and EKG are not diagnostic, why are we following these guidelines that are saying you need a mandatory stress test when all it's been shown to do is increase the number of procedures with potential complications? By the way, whenever somebody gets a stent, what other drug do they need to be put on? Clopidogrel, right? Aspirin, and clopidogrel for the next year. Have any of you ever seen a clopidogrel complication? All the time, right? So this doesn't even take into account the adverse effects from the anticoagulants and antiplatelet medications. This test specifically looked at coronary CTA, and take a look at what the take-home message was. Compared with existing standards of care for evaluation of acute chest pain, coronary CT angiography is associated with similar rates of major adverse events, but higher rates of revascularization. So we routinely get coronary CTAs in these low-risk patients, all it does is increase the number of patients that go for PCI and stents without improving outcomes. And by the way, also driving up the costs, right? So pretty interesting stuff. So what in the world are we doing? This is an interesting billboard, how the lawyers look at things. Just because you did it doesn't mean you're guilty, right? All right? So question right there. We'll talk about some of those variables in just a bit, all right, in terms of the HPI. All right, so why is this happening? I thought that stress testing was the gold standard. Stress test positive, they've got to get the test. Stress test negative, then you're off the hook. Well, we know provocative testing's not perfect, all right? Everybody knows that. Poor sensitivity, all right? It's not perfect. In general, no matter what stress test you look at, they have about an 80 to 85% at best sensitivity for picking up big coronary lesions. So they're going to miss big lesions. But what we weren't taught is that stress tests, and especially coronary CTA, bless you, especially coronary CTA, has very imperfect specificity also. Take a look at this study from 2012. Take a look at the specificities. They've got about 75% on average specificity. So I already knew they weren't perfectly sensitive, but I didn't know how non-specific they were. What that means is that there's a tremendous number of false positives in these, especially in these low-risk patients. So you send people, so if we take everybody in here, and I'm going to assume everybody here is healthy, you're not having any symptoms. If I send everybody in this room for a stress test, some of you are going to have false positive stress tests, right? What happens if you have a false positive stress test? You go for a cath, an unnecessary cath with all of those complications. Is it possible that you might have a false positive cath? Absolutely. What happens if you have a false positive cath? You get an unnecessary stent, or maybe an unnecessary bypass surgery. Both of those have been well documented in the literature as well. And it all starts with an unnecessary stress test, which leads to all the rest of this. What happens when you use a poorly specific test in a low-risk population? You get a lot of false positives, right? That's basic statistics. If you take a poor specificity test and apply it to a low-risk population, you're more likely to get a false positive than a true positive, right? Lots of false positives. And what happens when you get a false positive? You go for unnecessary cath and possibly even unnecessary CABG. It's documented in the literature. You guys remember this test called D-dimer? Remember when D-dimer was introduced to us? We were doing too many coronary CTAs. So they said, hey, there's this great blood test that you can use, and it doesn't have great specificity, but it's got really great sensitivity. So if you use D-dimer to help you decide whether to do a CTA to look for a PE, it's going to decrease the number of CTs without missing anything. So that was the D-dimer was given to us, and we were told to start using D-dimers. What happened to the rate of CTAs? It went up because people started using D-dimer in low-risk patients. And what happens when you use a poorly specific test in a low-risk population? A lot of false positives. So the number of patients getting CTAs increased. We were never supposed to use D-dimer in low-risk patients. That's the wrong group of patients to use it in. You're supposed to use D-dimer in intermediate-risk patients. All right? In fact, from the national guidelines, this is from the Annals of Internal Medicine, the American College of Physicians, the biggest medical organization in the world, put together an algorithm just a couple of years ago reminding us how we're supposed to use D-dimer. Take a look at this algorithm. Pretest probability. If the pretest probability is low, do you get a D-dimer? No, you use the PERC rule. You only use D-dimer when you've got an intermediate pretest probability. That's when you use the D-dimer. So when your Wells score or revised Geneva score is intermediate, that's the patient you use the D-dimer, not the low-risk patient, because if you use it a low-risk patient, you're going to increase the number of false positives. and that's going to result in unnecessary CTAs. Same thing applies to stress testing. Stress testing is not for patients that are low risk. It was sold to us that way, which is completely wrong. It's meant for patients with intermediate risk. So, do we have any guidelines to back up what I'm saying? We finally do. This is the most recent ACEP clinical policy published in 2018. And here's what it says. The test threshold, the point of probability at which harms associated with elevated troponin testing and workup exceed the risk of untreated disease, has been estimated to be approximately 2% for patients presenting with suspected cardiac chest pain. Many patients may be receiving extensive diagnostic workups for ACS in which the harms exceed the potential benefit. Reading through this, essentially what they say is that if you do your history, physical, EKG, and your pre-test probability of ACS is 2% or less, if you send them for a stress test, you're more likely to have a false positive stress test than a true positive stress test. You're more likely to induce more harm than benefit by sending these patients to stress testing when they are low risk. The biggest organization in emergency medicine has taken a bold step forward and said, stop doing stress tests in low-risk patients. Do not routinely use further diagnostic testing, either coronary CTA or stress testing or myocardial perfusion imaging prior to discharge in low-risk patients in whom acute MI has been ruled out to reduce the 30-day MACE risk. Stop doing stress testing when the pre-test probability is 2% or less, because you're more likely to get false positive stress tests, and that's going to be associated with an increase in harm. You now have backing from the biggest EM organization in the world to say, you know what? When they say, show me the literature to say why you didn't follow the guidelines, you now have a clinical policy from the biggest EM organization in the world with good data to back you up. You now have something in your hands. So the next question that you may be asking, well, you're saying 2%. How in the world can we predict if somebody's risk is 2%? Is there any way that we can tell if somebody's risk is 2% or less? The heart score. Now, you heard a little bit earlier about the heart score during the lunch session, and I wasn't here, but I heard that they weren't necessarily real great or positive about the heart score. If you want to use the EDAC score, fine. If you want to use the TIMI or ADAPT score, fine. Just make sure you're using a validated protocol. All right? I'm a big fan of the heart score because it's easy, and I love mnemonics. HEART. I can remember that. All right? Even without having to pull out my smartphone, I can remember what HEART stands for. And it's the most highly published and most validated accelerated diagnostic protocol in the world, in our specialty. All right? Here's the heart score for those people that are not familiar with it. 5 scores, HEART, each one of these gets up to 2 points. And when you add up the points, using one conventional troponin, this is the original data, all right? Not even highly sensitive troponin. They used a normal troponin, and they used it at the time of arrival. If somebody has a heart score of 3 or less, their rate of major adverse event at 6 weeks was under 2%. So you now have a validated, an internationally, externally validated score that can predict when your patient is under 2% risk. Right? If 1.7% is too high for you, you can get a second troponin. Multiple studies have validated, if you want, get a second troponin at 3 hours after arrival. If the second troponin is also less than, or is also normal, so heart score is 3 or less, and now you've got 2 negative troponins, your rate of adverse event at 1 month is less than 1%. It's about 0.6%. All right? I always like to recommend getting a second EKG also with that second troponin. So we've got internationally, externally validated scores that can tell you when your patient has less than 2% risk and therefore is going to get more harm than benefit by the mandatory stress test or coronary CTA. All right? And this is the most recent article that came out looking at the heart pathway. The heart pathway is the term that refers to getting a troponin at arrival and then another one at 3 hours after arrival. Heart score is endorsed by the AHA. It's also endorsed in ACLS, in the chapter on ACS. It's endorsed in the ACEP clinical policy that we just talked about. It's talked about in numerous other articles internationally, journals everywhere. It's internationally, prospectively, and externally validated, all right? The EDAC score is also validated. The ADAPT score is also validated. The Vancouver chest pain rule is pretty much validated. So I'm not going to say you've got to use a heart score, but just make sure you're using, if you're using a score, make sure that you're using one that has been externally validated. And any of those, in my opinion, would meet standard of care. So quick take-home points. There is markedly increasing literature supporting the idea that we do not have to routinely be following stress testing or coronary CTA in low-risk patients who meet one of these validated accelerated diagnostic protocols. Because routinely doing that is associated with increased length of stay, increased cost, increased subsequent invasive procedures, and no reduction in the rate of major adverse cardiac events. So why bother sending them for PCI and CABG if you know it's not associated with an improvement in outcome? It doesn't make any sense. All right? So, question again, are these now defensible? I would say absolutely yes, with a couple caveats. All right? Number one, you've got to use it correctly. I mentioned this yesterday or earlier today. If you're going to use an accelerated diagnostic protocol, use it the way it was researched. Don't come up with your own scores. Don't go rogue with it. All right? Use it the way it was published. Use it the way it's on your smartphone. All right? Do a great history and document it. We talked about that earlier. I like the old car mnemonic. I document my old car HPI on every chest pain and belly pain patient I've seen since I finished residency, and actually since I learned it in medical school in the early 90s. All right? Every time. All right? Add the points and properly document them. And then use a standardized approach to the H. The biggest question or quandary that comes up is, how do you come up with a score for the H, the history? The history part of the heart score is a bit subjective. So what we've done is we've looked at the international literature. There's a handful of really great articles. And, you know, the classic history for ACS is chest pressure, tightness, squeezing, radiating to the left arm, left neck, left jaw, with shortness of breath, nausea, vomiting, diaphoresis, lightheadedness. It felt just like my previous unstable angina. Everything I mentioned is classic. But when you actually look at the big studies, at all the different factors I just mentioned, this goes to your question, right? There's only 4 that have the highest predictive value for ruling in for ACS. So what we've done is we've taken these 4 and we use these 4 in our 14 hospital network around the state of Maryland. What are the 4 factors that have the highest predictive value for ruling in for ACS? Chest pain plus diaphoresis, chest pain that worsens with exertion, chest pain that radiates, and by the way, bilateral radiation is the worst of all, followed by radiation to the right side. Least concerning is radiation to the left side, all right? But we don't complicate things. We just say if it radiates in either direction, all right? And then chest pain with vomiting, not nausea, but vomiting. The descriptors, tightness, squeezing, pressure, they've all been shown to be nonspecific. Associated shortness of breath has been shown to be nonspecific. Associated nausea or lightheadedness, nonspecific. The only 4 that have the highest predictive value are chest pain with diaphoresis, chest pain with vomiting, chest pain that worsens with exertion, chest pain that radiates in either direction. So what we do in our entire network is, for the heart score, the H score, we ask those 4 questions to every single patient, and it gets documented. In fact, it's incorporated in our EPIC computer system. You cannot evaluate patients with chest pain without answering those questions on the computer. If you have none of those 4, you get a 0 for H. If you have one of those 4, you get a 1. If you have 2 or more, you get 2 points. And the maximum score is 2. So that's what we do within our system. So we have a literature-based, very standardized approach which every physician in the entire University of Maryland network follows, and they ask those 4 questions to everybody, and that's what we do. That actually got brought up at a deposition one time, almost as if it's become standard of care. At least to that lawyer it was. All right? So come up with some type of standardized approach to the H, and don't go rogue with this. And if you follow these things, I believe it's very, very defensible. By the way, both the plaintiff and defense attorneys know the heart score, and I've seen them repeatedly ask about the heart score during the deposition. Now, if you say we don't use the heart score, then they're not going to ask you more about it, but they will ask what you use instead. And if you're not using something else instead, they're going to pull out the guidelines. So I suggest you start using an accelerated diagnostic protocol. Again, take your pick amongst the various ones. So, question, yeah. We just do the same thing. Even taking into account women having atypical risk factors. In the original heart score, they didn't exclude women, so they, as far as I'm concerned, they're validated. Now, I think it's important to have a lower threshold with atypical presentations, but in terms of the actual heart score, we're not changing anything, all right? You are allowed to have some gestalt and some subjective nature, and that's where that kind of plays in. All right. Quick take-home points. Increasing literature suggests that routine provocative testing or CTA for low-risk chest pain, when the risk is under 2%, is associated with increased length of stay, increased cost, increased subsequent invasive procedures, no reduction in major adverse cardiac events. All right? Now, if the clinical evaluation suggests a higher risk, then you send them for further testing. So what I would advocate for, if you're using the heart score again, heart score is 0 to 3, discharge. No stress testing. They follow up with their primary care physician, and the most important thing you can do for those patients is aggressive risk factor modification. Get them into a smoking program. Get them into some type of diabetes training program. Get them on hypertensive. Get them into see their primary care doc so that they can get all that stuff started. That's the most important thing you can do to decrease their risk. Heart score 4 to 6, those are the intermediate risk patients that I believe are most going to benefit from the stress test or the coronary CTA. Heart score of 7 or more, they're all coming in for aggressive management. All right.